Assalamualaikum. Now the discussion is a recall clinical case thalassemia. So first of all, we can follow the examination technique per abdomen I have shared, and then present your case. So this is well-looking adolescent boy of Asian origin who looks well-grown. On inspection, his hand there is multiple scar from IV cannula. His sclera has tinge of jaundice, and on examination there is palpable spleen, and there is some depigmentation mark on abdomen. And I think it's a case of thalassemia, and I would like to plot his height, weight on a growth chart and do the pubertal assessment. As in some cases, if this is poorly treated, not getting the chelation therapy or not getting the proper hyper transfusion therapy, there may be thalassemic phase is present, by which is I can appreciate malar prominence, depressed nasal bone, malocclusion of the teeth, prominent occiput, and there may be cannula mark is present, and patient is icteric, and there is hepatosplenomegaly is present. And to complete my examination, I want to do the anthropometry. This two different way and different presentation may be happen. So then the question is, what investigation you would like to advise. So first of all, I will revise his previous note and diagnostic investigation, hemoglobin electrophoresis, where I expect hemoglobin in case of thalassemia major, hemoglobin A absent, A2 present, more than 2%, and more than 95% hemoglobin F, and full blood count macrocytic hypochromic anemia with reticulocytosis, and blood film anisocytosis, poikilocytosis with target cell. And then how will you manage the child? I will go through his previous history and records, and following the investigation, and I will if the child is hemodynamically stable, so I will go through the multidisciplinary team approach, and here I will involve my consultant, hematologist, cardiologist, psychologist, genetic team, specialist nurse, liaise with school. And management will start from hypertransfusion therapy, aim to reach the hemoglobin more than 10, and prevention of the iatrogenic iron overload by the chelation therapy, and folic acid supplementation, splenectomy if needed, and gene therapy, and definitive bone marrow transplantation, and genetic counseling, and I will keep the child under follow-up. And then recall question was that what are the DD of chronic hemolytic anemia. So thalassemia is the top of diagnosis, hereditary spherocytosis, sickle cell anemia. And another recall, how to assess the iron toxicity. So MRI of the brain, heart, serum ferritin level, and biopsy of the tissue iron storage monitoring. Complication of thalassemia. So complication of thalassemia, complication due to thalassemia itself, and complication due to iron overload. So the complication due to thalassemia is that hepatosplenomegaly, expansion of the bone marrow, pathological fracture, impaired growth and puberty, anemic heart failure. And complication due to iron overload, this is endocrine complication, liver complication, cardiac complication. Endocrine complication, delayed growth and puberty, hypothyroidism, hypopituitarism, diabetes mellitus. Liver cirrhosis, cardiac arrhythmia. And one recall question was that when we will refer to the endocrinologist if there is short stature, delayed puberty, hypothyroidism, diabetes mellitus, osteoporosis, and hypoparathyroidism, then we will refer to endocrinologist. And A thalassemic child now complains of bed wetting. So what may be the cause? We should search for diabetes mellitus. And thalassemia with splenectomy child now presents with fever. So we will consider the infection by capsulated organism such as the pneumococcus, meningococcus, haemophilus influenzae organism. And then indication of splenectomy and precaution. So indication of splenectomy if there is feature of hypersplenism, which is a trait of splenomegaly, various levels of cytopenia and compensatory bone marrow hyperexpansion. And the cytopenia, various level of cytopenia will be improved after splenectomy. This is the hypersplenism, and it is one of the indication for splenectomy. Another indication is if it is mechanically causes discomfort, causing early satiety, fear of rupture. These are the indication of splenectomy. So the precaution for before splenectomy is better to do after 5 years. Wear the bracelet, extra vaccine before splenectomy, penicillin prophylaxis, and avoid crowd place. And then another question was that how will you follow up? So follow up, it depends upon the institution. And so monthly full blood count, 3 monthly serum ferritin, random blood sugar, SGPT, creatinine, albumin, 6 monthly echocardiograph, ECG, and yearly screening for hepatitis B, C, and screening for the endocrine disease, so growth hormone, FSH, LH, and free TSH, free T4, glucose intolerance test, hearing, vision, monitoring, and anthropometry and pubertal staging. And what are the chelation therapy with complications? So chelating therapy, dysferoxamine, and it is subcutaneous, and side effect is the vision, sensorineural hearing loss, infection by Yersinia, and renal complication, depigmentation, and diferriprone and deferoxyrox. And here these two drugs can cause arthropathy and neutropenia. And oral medication takes time up to 1 year to start its function. And another thing is that during splenectomy, before splenectomy, what investigation we will suggest? This is ultrasonography. And during splenectomy, some school in told that you can do during the splenectomy appendicectomy, and some thought was during this splenectomy we can do the cholecystectomy and also the appendicectomy. And causes of hepatomegaly in case of thalassemia. So the hepatomegaly may due to extra medullary erythropoiesis, heart failure, hepatitis, and hemosiderosis. Causes of bone pain, pathological fracture, side effect of iron chelation therapy, hypoparathyroidism. What are the causes of obesity in case of thalassemia? So hypothyroidism, growth hormone deficiency, depression. Thank you.